with Dr. Hitin's talk. So he would be speaking about the Hallux valgus.
Can you hear me now?
Yes, we can, Hitin, and we can see your screen also. Go ahead, please.
How do I make it full screen?
Go to the slideshow. Yeah, you can go on to slideshow. I think you can minimize your video on this side. You hide the thumb. Okay.
Okay. You can see the full screen now?
Yes, we can.
Okay. So at the onset, I would like to thank IFAS for the opportunity. I'm Dr. Mathur, and I'll be talking to you about Hallux valgus. So I'll be covering the topic under the following headings. So let's come to the deformity itself. So the term Hallux valgus was coined by Carl Hutter way back in 1870. And he described it as a static lateral dislocation of the great toe and a medial deviation of the first metatarsal. Since then, we have come a long way in understanding the deformity itself, so much so that in 2014, Dayton proposed the term Hallux abductovalgus with metatarsus primus abductovalgus to define the multiplanar nature of the deformity. Here, the term valgus is used to denote the rotational or the valgus or the pronational component of the deformity. So the deformity is in the sagittal plane, in the transverse plane, and also in the frontal or the rotational plane. So it is a triplanar deformity. So about 2 to 4% of the population is affected by Hallux valgus. Females are more commonly affected in the 3rd to 5th decade of the life or in the juvenile age group. It has a familial history with a maternal transmission. The etiology is multifactorial and is controversial at best. So what do these patients come to you for? So these patients will probably come to you for pain either in the medial eminence or in the plantar aspect of the foot. They may have an altered gait or an imbalance, especially in the elderly population. The younger population will probably come to you for a cosmetic appearance or difficulty in wearing the high fashionable footwear. So when these patients come to you, you need to examine the foot. And as all foot and ankle examinations, you proceed with the examination of the gait, examination in standing, and examination in the sitting and the lying down position. So as far as the foot examination is concerned, you can either proceed from distal to proximal or from proximal to distal. So if you proceed from distal to proximal, you should examine the hallux, the medial eminence and the first MTPJ joint, the first ray, the lesser toes and the metatarsals, the hind foot and the midfoot. Along with that, you should also do a neurological and vascular examination of the foot, and you should look for generalized ligamentous laxity with a Beighton score. So as far as the hallux is concerned, you should look for hallux interphalangeus or extendus, a delta phalanx, or a long hallux. In the medial eminence and first MTPJ region, you should look for synovitis or arthritis of the first MTPJ joint, erythema of the medial eminence, irritability of the dorsomedial cutaneous nerve, which is in that region. You should also look for range of motion of the first MTPJ joint and the reducibility of the sesamoid apparatus. As far as the first ray is concerned, you should look for motion and reducibility of the first ray in all 3 planes. You should also look for the length of the first ray and pain, arthritis, and instability of the first TMT or the navicular cuneiform joints. So this is a picture which shows how you examine the first ray in the sagittal, the transverse, and the rotational plane, and the reducibility of the deformity or the flexibility of the deformity is all 3 planes. So as far as the lateral metatarsals are concerned, you should look for signs of metatarsalgia, which will have a bunion or a callus on the 2nd or the 3rd metatarsal heads, or you should also look for other toe deformities like a cross-forward toe. In the hind foot and midfoot, you should see if the patient has a pes planus or a flat foot or a metatarsus adductus, and you should examine for ankle inquinus with the silver score test. So once you've examined the patient in the foot, you should assess the deformity radiologically, and the radiological parameters that are used to assess the foot are the X-rays and a 3D CT scan, and even a weight-bearing CT scan if it is available in your region. So what X-rays do we need to do? We need to do X-rays of the foot in the AP, lateral, and the sesamoid axial views. So on the most important view is the AP view. And what are the things that you need to look for in the AP view are the 5 angles, 2 joints, and the position of the sesamoid apparatus. So what are the 5 angles? The first angle is the hallux valgus angle, which is the angle between the mechanical axis of the first ray and the hallux, and it should be less than 15 degrees. The second angle is the intermetatarsal angle, which is the angle between the first and the second metatarsals, and it should be normally less than 9 degrees. The third is the hallux interphalangeus angle, which is the angle between the proximal and the distal phalanx of the hallux, and it should be less than 10 degrees. The other 2 angles are the distal metatarsal articular angle, which is the angle made by the distal articular surface of the first metatarsal and the mechanical axis of the metatarsal, and it should be less than 6 degrees. And the last angle is the metatarsus adductus angle, which is the angle that the forefoot makes with the midfoot axis, and it should be less than 15 degrees. The joints that need to be seen on the X-rays on the AP view are the first MTPJ and the first TMT and the navicular-cuneiform joint. For the first MTPJ, you should look for the congruence of the joint and for arthritis of the joint. The picture on the right depicts a congruent joint, and the picture on the left depicts an incongruent first MTPJ joint. As far as the first TMT and navicular-cuneiform joints are concerned, you should look for arthritis of the joint, and you should also look for increased plantar gap on these joints, which is indicative of a first ray instability. On the APU, you can also assess the rotational component of the deformity by noting the position of the tibial sesamoid. So 4 is the central position, and anything beyond that is subluxated or a dislocated sesamoid. The rounding of the lateral metatarsal head and concavity of the lateral metatarsal shaft also suggests that there may be a rotational component of the deformity. On the lateral X-ray, you can assess the sagittal plane of the deformity by the Meares angle or the talo-first metatarsal angle and the parallelism of the first and second metatarsal cortex. The gaping of the first TMT or the naviculo-cuneiform joint, the plantar gaping, also is used to assess the first ray instability or a sagittal plane deformity. The sesamoid views are used to assess the rotational component of the deformity, and in that you can see the angle that the first metatarsal makes with the floor, or as in the picture on the right, you see a sesamoid which is subluxated, which is indicative of an incongruent joint. So what are the treatment options? So treatment options can be surgical or non-surgical. The non-surgical treatment options include toe spacers, braces for the hallux valgus, orthotics, and footwear modifications. So if these treatment options do not work and the patient's symptoms still persist, then it is time for surgery. So the decision for surgery is not just based on the severity of the deformity, but also other parameters like the age, occupation, level of physical activity and athletic inclinations of the patients, the footwear preferences, and the patient expectations. For example, if you offer a first MTPJ arthrodesis for a patient who may be a ballet dancer or who may like to wear high-heel shoes, she may not be very happy with your decision in spite of the fact that you may have given a perfect anatomical correction. So once you decide for surgery, you need to know whether the deformity is mild, moderate, or severe based on the hallux valgus in the intermetatarsal angles. So what are the surgical options available? So the surgical options are either a distal soft tissue procedures, osteotomies, first MTPJ arthroplasties, or arthrodesis. As far as arthrodesis is concerned, you can either arthrodese the first MTPJ or the first TMT joint, which is also called the lapidus procedure. As far as osteotomies are concerned, they can either be done in the hallux, which is called an Aiken osteotomy, in the metatarsal, or in the cuneiform. Metatarsal osteotomies, in turn, can be done in the distal part of the metatarsal, in the shaft, or in the proximal part of the metatarsal, based on the severity of the deformity. The distal soft tissues procedures are usually indicated for incongruent joint, and they involve releasing the structures on the lateral side of the joint and tightening the structures on the medial side of the joint. It is important to remember here that they're never done in isolation and should always be combined with an osteotomy to prevent the recurrence of the deformity. The distal metatarsal osteotomies, there are a number of them, and with different modifications, with different names. But they are mainly indicated for moderate deformity, and the disadvantage is that they do not offer a rotational correction. The scarf, the proximal metatarsal, and the cuneiform osteotomies are indicated more for a severe deformity, and they have an advantage of offering a rotational correction as well as some lengthening or shortening of the first ray. The first TMT, or the lapidus joint fusion, or the lapidus procedure, is usually indicated for first TMT arthritis or first lay instability, and they have an advantage of offering a triplane correction. So how do I decide on what treatment to offer? So the traditional treatment algorithm is based on the status of the first MTPJ joint and the severity of the deformity. So if the joint is incongruous, you would add a distal soft tissue procedure along with an osteotomy. And if the joint is arthritic, you would offer a first MTPJ fusion. So similarly, if the deformity is mild, you would probably err on the side of going to a distal osteotomy with or without a distal soft tissue procedure, depending on the congruency of the first MTPJ joint. If the deformity is severe or moderate or severe, you would offer a proximal osteotomy, and you may offer a lapidus or a first MTPJ arthrodesis, depending on the arthritis or the state of those joints. So in 2017, a new triplanar classification was offered by the VBB working group, and they divided hallux valgus into 4 classes. The class 1 was the traditional biplanar deformity, which was treated in the traditional way, and class 2 to 4 was a triplanar deformity, which they proposed. So again, class 2 was subdivided into patients who had a sesamoid subluxation and those who did not. So patients who had a triplanar deformity with a sesamoid subluxation underwent a distal soft tissue procedure along with a triplane correction, whereas those without had a simple triplane correction. Class 3 had an additional metatarsal adductus deformity, which needed a second and third metatarsal basal osteotomies to correct that component of the deformity along with the triplanar correction. Whereas class 4 had a first MTPJ arthritis, which needed a first MTPJ joint arthrodesis. So to summarize, hallux valgus is a multiplanar deformity with a multifactorial etiology. A comprehensive examination of the entire foot and ankle can help to visualize the 3D nature of the deformity. X-rays and 3D CT further help to delineate the components of the deformity. And knowledge of and diligent choice of surgical procedures as per a logical treatment algorithm can help to achieve better patient outcomes. Thank you for your time.
Thank you, Dr. Hitin. Thank you for that wonderful presentation on the hallux valgus. I think